Okay, so first off, before we begin, I'd like to bring attention to the reading. I looked at your syllabus when I was preparing, and I saw that this chapter here in your syllabus is 17, but really in the new edition it's 16. It's the fluid and electrolytes chapter. So please go back and review that. Don't go looking in chapter 17 because I won't be looking in chapter 17. So it is chapter 16. Yeah. Okay. So hypokalemia is a problem in which the amount of potassium in the blood is lower than normal. Okay, it results from decreased potassium intake. That's one, decreased potassium intake. Two, a shift of potassium from the extracellular fluid into the cell. A shift of potassium from the extracellular fluid into the cell, so intracellular. So one is decreased potassium intake. And two is a shift from the extracellular space to the intracellular space. Ooh, Chick-fil-A, yum. That's fine. It results from one, a decrease of potassium intake. That's one. Two is your potassium shifts from the extracellular fluid to the intracellular fluid or inside the cell. And three is increased potassium output. Our kidneys are releasing potassium, or we're having lots of diarrhea, or we're throwing up a lot. So three, increased potassium output. All right, so what puts us at risk for developing hypokalemia? I just said diarrhea and vomiting repeatedly, not just one time. We're talking excessively vomiting or excessive diarrhea. And also gastric suctioning. Okay, that's why we don't stick an NG tube down to our NPO patient and just hook it to continuous wall suction, because it's just going to suck out all their gastric secretions and could cause them to develop hypokalemia. Okay, that's the same reason why when we're taking care of our critical care patients and we're aspirating those enteral feedings to see how much they're digesting, or if they're just keeping it in their stomach, we don't just dump it down the toilet. Okay, because that can cause an electrolyte imbalance, specifically hypokalemia. Okay, so ileostomies can, because it's a shorter path of absorption for potassium. Potassium-wasting diuretics, polyuria, excessive aldosterone. Okay, so what does aldosterone do? Yes, very good. So it's a hormone that is secreted when sodium levels are too low, and it tells our kidneys to retain sodium. It also tells our kidneys to get rid of potassium. So if aldosterone is being secreted, then it helps us to hold on to our sodium, but it releases a lot of potassium. And wherever sodium is, what follows? Water. Good. Okay, so if your potassium levels become high, your body should secrete more aldosterone to help you get rid of potassium. Okay, so what disease process excretes excessive aldosterone? Cushing's, yeah. Okay, so Cushing's. Eating disorders, like anorexic disorders where you're not eating and taking enough food, or malnutrition. Excessive corticosteroid therapy causes that same similar phenomenon as Cushing's. Treatment of DKA with regular insulin. Okay, so if my patient's sugar is really high, we're going to put them on a regular insulin drip. And what does regular insulin do with potassium? Good. Helps potassium go back in the cells. It's like buddies. Come on, buddy. I'm going to the cell, I'm bringing the sugar, and I'm bringing the potassium. But that also puts our patient at risk for developing hypokalemia. Alkalosis can cause hypokalemia. Okay, so when we're alkalotics, especially metabolic alkalosis, our potassium will shift into the cell and to get our hydrogen to come out of our cell, because we're trying to make our cells more acidosis. We're trying to fix our acid-base imbalance. So if you're very alkalotic, your potassium will try to go in the cell and your hydrogen will try to come out. Okay. If patients are on IV therapy with little or no potassium and they're NPO and they're not taking in anything, but we're filling them full of lots of saline, it can cause them to become hypokalemic. And then low magnesium levels can also cause hypokalemia because it stimulates our renin-angiotensin-aldosterone system, which has our aldosterone in it, which tells us to get rid of potassium. Okay, 98% of our total body potassium is inside our cell. So most of our potassium in our body is inside our cell. And normal serum potassium levels, what? 3.5 to 5. Right, very good. So hypokalemia is anything less than 3.5. Okay, so with reduced potassium, that also results in reduced excitability of our cell. So if you're a nerve or a muscle cell, this also means you're a little less responsive than what you normally are. Okay? A little less responsive than what you normally are. So slow gradual loss allows our cells to kind of help us compensate and release some of that potassium into our extracellular fluid. Okay, so we might be slow to show signs and symptoms of hypokalemia because our body's trying to compensate. Because 98% of our potassium is in our cell. So our cells are like, yeah, I can give a little. So we might not see all those signs and symptoms of hypokalemia until our potassium level is extremely low. So rapid reduction of serum potassium causes dramatic changes in function. Okay? And what controls our potassium? Most of the potassium in our body. Keeping it and getting rid of it. What organ? Kidneys. Our kidneys are responsible for 90% of our potassium removal. Okay, everything else, the other 10% is sweat and stool. So what does our patient look like? What are the most common clinical manifestations? So I found suction on there, but I wanted to add R, so it kind of sounds a little piratey. So R, suction. R. Not argatrogram, just R, suction. Okay, so hypokalemia alters our resting potential in our nervous cell, making it hyperpolarized. Okay? It requires an increased stimulus to move that membrane potential to the action potential threshold because there's such low potassium. Okay? So R is respiratory. Common clinical signs, respiratory. You're like, where did that fit in there? Yeah. Sorry. I wanted to put that thought out there, and then I already looked at the screen and wanted to talk about that. Sorry. So what does R section say for? R is respiratory. Weak muscles, especially the diaphragm. Put your patient at high risk for respiratory issues. Okay? So you want to check on your respiratory status of your patient at least every 2 hours, because respiratory insufficiency is one of the leading causes of death, hypokalemia. So R, respiratory. Okay, S is skeletal muscle weakness. Skeletal muscle weakness. Okay? They need a stronger stimulus to cause a muscle contraction. So these patients can be too weak to stand. They can also have decreased deep tendon reflexes. Okay, so they need a stronger stimulus to begin muscle contraction. They may be too weak to stand or very weak in moving. They may have decreased deep tendon reflexes. Okay, U is for U-wave. U-wave. I know we didn't talk a lot about U-waves in EKG, but we're going to talk about them now. A U-wave is thought to represent the repolarization of the Purkinje fibers. It's not present most of the time. But when you're hypokalemic, a U-wave can be present. Okay? They may also have ST depression, flat, or inverted T waves. Okay, so the T waves are usually a nice little curve. They may be flattened looking or flipped upside down. So U is for U wave. C is for constipation. Again, muscle contractions, that's smooth muscle contractions. So they may become constipated, they may develop an ileus. Assessed for hypoactive vowel sounds, distension, nausea or vomiting because they're not moving things around. T is for the toxic effect of digoxin. Toxic effect of digoxin. And why is that? Right, opens up more room on the receptors. So I think I told you that before about the movie theater seating. So I think of digoxin and potassium like they're going to a movie theater. And you want the right balance, but if you have not enough potassium, then there's more seats for digoxin. If you have too much potassium, then you have less seats for digoxin. So this would give them more of a toxic effect of digoxin. I, irregular weak pulse, thready, could have some dysrhythmias. So I, irregular weak pulse, thready, could have some dysrhythmias. O, orthostatic hypotension. Okay, O, orthostatic hypotension, and N, numbness or paresthesia. They could also have other neurosigns like lethargy, confusion, and coma. I can't say I've ever seen a patient that's just been so hypokalemic that they're in a coma, but somebody out there says that. So there you go. All right, so looking at our picture here, we're going to talk about hyperkalemia in a little bit. But hypokalemia, you have our nice normal kalemia EKG right here. And you can see there's a teeny little V wave, the nice rounded T waves. If you look at our hypokalemia, we have that prolonged PR interval, this little ST depression, and our T wave is kind of shallow compared to that one. And you have a nice U wave right there. So a little different looking. And then when we get to hyperkalemia, I know we talked a little bit about that, but you have the peaked T waves. I always call them the witch's hats. Okay, if you have witch's hats that follow your QRS, then that's a sign that you're in hyperkalemia. So we want to ask the patient about their diet. Okay, the first blank is diet. What foods are they eating that are high in potassium? I mean, that seems kind of like common sense. What are you eating? Medication regime, that's your second blank. Okay, are you taking any potassium-wasting medications? Are you on digoxin? Because we don't want them to be taking that and having low potassium. And what their health history is. Health history is the last blank there. Okay, our goal is to prevent potassium loss, increase serum potassium levels, and ensure patient safety. So what drug do you think we're going to get? Potassium. Yeah. Not with the Mr. Yuck sticker. All right, so there's various concentrations of potassium. JCAHO mandates that only the pharmacy can add concentrated potassium to IV solutions. Since I've been a nurse, which has been 15 years now, I've never seen a vial of potassium just hanging out at the nurse's station. However, some nurses that were more senior than me have said that they used to keep potassium vials at the nurse's station. So they do exist. So if you see that and you're in a code situation, this is where you most oftentimes see nurses mix meds at the bedside in IV solution. Don't ever do it. Don't ever mix potassium. That you'll get yourself into trouble. Okay, it's not that dire of a need to mix potassium at a bedside in a code situation. So no vials of potassium in patient care areas. That is a JCAHO standard. No IV pushing potassium. That is a big no-no. You cannot give it sub-Q or IM. That will cause necrosis in your tissue, and it'll burn, and your patient will give you a terrible review, and you'll be sad, and he'll be sad, and it'll be a bad time for everybody. You should make sure you have a good IV site prior to starting your infusion, okay? Because if it infiltrates, it's going to cause necrosis of that tissue. So make sure you have a good IV site, or central line is most preferred because that's in a bigger vessel. Also, I try to start an IV that's in a bigger vein, not just the little ones in your hands. Okay? Try to find a bigger vein if you can, because it's very irritating to the vein. It'll burn. Your patient will say it's burning. It won't take but like 3 minutes, and they'll be complaining that it's burning. So the bigger the IV, or the bigger the IV and the bigger the vein, the less likely you are to have burning or irritation of that vein. Okay? So we typically give potassium 5 to 10 milliequivalents per hour. Okay? So in an IV, on a med-surg floor, 5 to 10 milliequivalents per hour. If you're in a critical care area and you have a central line, you can give it up to 20 milliequivalents per hour with EKG monitoring. But it has to be through a central line. It has to be with EKG monitoring. And then you always want to follow your hospital's policy and procedure when it comes to administering potassium. Most hospitals have a policy written about how fast and what floors you can run, how fast you can infuse in potassium and on what floors and what lines they have to be run through. So it's very damaging to our tissues. So if it infiltrates, it'll cause necrosis and sloughing. So you might want to write this down. If you have infiltration, this is what you want to do. Stop your infusion. Remove your IV. Notify your healthcare provider. Okay? And you'll probably have to start an IV on another site. A lot of times we'll put like a warm pack around it to kind of get the medicine to get absorbed in the skin. We don't want it just hanging out and eating up and being necrotic on your skin. Okay? And then you'll want to start another IV and restart that potassium infusion. Yes, Eamon?
Is this place something warm or an ice pack?
Warm. Yeah. Because you want your tissue, you want it to start getting absorbed. If you keep it there, if you constrict everything, then it'll just stay in that tissue and it'll start eating away the tissue. All right, and then document the actions. What did you do to take care of your patient? And a complete description of your IV site, not just right arm, IV infiltrated. Now you want to be very accurate. Right forearm, and then what the site looks like, how big, is it red, is it swollen, what does it look like, is it blanching, not blanching. So you want to document everything that you can. You want to mark the site. That way each nurse that's coming on can also look at it and know kind of where that infiltration was and what was going on there. Okay? Orals can be liquid or solids. Okay? So with liquids, you can use that for NG tubes or PEG tubes or Mickey buttons. OG tubes. You never want to crush or chew the oral medication because it's extended release. Okay, so I know sometimes they got that Cater. How many of you guys have given Cater this semester? A couple, yeah. You can break it apart because it is breakable this way, but you can't chew it. So what I see a lot of times is the nurses will try to sneak it in with applesauce to your patient that has dysphagia or difficulty taking medication, and they sit there and they chew it, and then they're like, this is the worst tasting medicine, because it really is really bad tasting, but that also is an extended release pill. So if they're chewing it, they're releasing the potassium right away. So if they're one of those types of patients, that might not be the right thing to do, is to have them kind of chew on that pill. Christina, you're giving me a look of like, you gotta be kidding me. It's true. Yes, Jessica.
So it's okay to break it in half, but not to crush it?
It is okay to break it in half. Yeah, it is, I can't think of the word. Excoriated, yeah. So you can break it in half, you just can't chew it. Scored. What did I say? Excoriated. I'm sorry.
We know what you mean.
I'm there. Scored, yes, excoriated. Yes, you should not be crushing it up. Yes. What? No, you should not chew extended release. You can break it in half to make it smaller, because it is a big pill. Abby? You're not supposed to. You're not supposed to. In the NCLEX world, you would never do that. And as a competent nurse with integrity, you would never do that either, because you would never want to put your patient at risk. I'm not going to say that I haven't seen it done. Believe me, I've seen it done. The other thing that they have is capsules. Those are a little easier. So if you have a patient that's having a hard time swallowing the Cater, which is kind of a big white pill, they do have the 10 ml equivalent capsules. And those are a little easier for patients to get down who can't swallow that big pill whole. So you might ask for that. Or you can always ask for liquid. All right, so safety interventions. So fall precautions, because they're weak gait, possibly bed rest if they're that weak and they shouldn't be getting out of bed. Okay, telemetry monitoring, because we could have some dysrhythmias. Pulse oximetry monitoring, because they're at high risk for respiratory issues. Okay, we're going to monitor for signs and symptoms of respiratory distress and hypoxia. So what are we going to do? We're going to teach our patients, hey, if you're not eating, eat. Okay. Eat more potassium-rich foods, except when taking potassium-sparing drugs like Spiral, Aldactone, which keeps our potassium for us. And there's just a small list: bananas, oranges, dates, raisins, plums, fresh vegetables, potatoes, meats, yay, legumes, because that's in every hospital's dietary thing. Let me give you some legumes. We also want to teach our patients who are taking diuretics and on loop diuretics and on digoxin that they should be taught digoxin toxicity, what those signs and symptoms might be, because they're at high risk for that. And then they also need to avoid large amounts of licorice, because licorice root can actually cause hypokalemia. So no Twizzlers. Excess amount of Twizzlers. Ooh, no, I think it's the black ones, right?
I was going to say.
Yeah. I think the red ones are okay.
Does anybody like licorice?
My grandma loves black licorice. Oh, yeah.
The good stuff they'll put in Sprouts.
It's like the leftover Halloween candy.
Yeah, it's Sprouts. You can buy the fresh good stuff.
The fresh good stuff.
Fresh good stuff. It's supposed to be good for you too.
But not if you're hypokalemic. It's not good. Or if you're at risk for losing your potassium. Okay, hyperkalemia. So that's serum potassium levels greater than 5. Ooh, sorry. Okay, it increases our cells' excitability, overstimulates our cells. Yay! Okay, that's why our ventricles don't like high potassium, because they don't like to be overstimulated, right? They get irritated and they get all sorts of fun rhythms like ventricular tachycardia, ventricular fibrillation. And hyperkalemia can also cause heart block too. So rapid rise of potassium in our blood causes severe problems fast. Okay? We usually start seeing signs and symptoms of hyperkalemia when they reach 6 to 7 in a rapid rise of potassium. So what is an example of a patient that might have a rapid rise in potassium? Crush injury. Very good, Joe and Leanne. And somebody over here. Because 98% of our potassium is in our cells, so if we get crushed somewhere, anywhere, those cells are going to release that potassium into our bloodstream right away. It also releases myoglobin, and what does myoglobin do? Plugs up our kidneys, causes rhabdo, and then you have some kidney problems, and our kidneys are in charge of doing what? Getting rid of potassium. So you have that you have double problems there when you have a crush injury. All right, slow rise may be slow to demonstrate problems. So patients you might not see clinical manifestations until they hit higher numbers from like 7 to 8. So increase in total body potassium, we've ingested too much, we've given too much, we've given it to a patient that shouldn't have had it, like a kidney patient, now they can't get rid of it. Or a patient is slowly becoming like a ICU patient that's been on vasopressors and things are slowly shutting down. You'll start seeing your potassium start rising because those cells are slowly dying and releasing the potassium. Or if our potassium is being pushed out of our cell for some reason. Okay, if we're very acidotic, our potassium will start moving out of our cells into the blood. All right, so causes too much potassium containing foods or medications. Okay, I decided to go on a diet. I'm now eating 12 bananas a day. Okay, hopefully you don't need anybody that extreme, but you never know. So too much potassium. Transfusion of packed red blood cells, like multiple transfusion of packed red blood cell, okay, or whole blood. Kidney failure is the most common cause of hyperkalemia. Adrenal insufficiency can cause hyperkalemia. So why does adrenal insufficiency cause hyperkalemia? Huh?
The failure with the angiotensin aldosterone.
Right, it's the failure of ROS, and the aldosterone, the failure to secrete aldosterone. And so we keep all of our potassium instead of getting rid of it. So it's the opposite of Cushing's. Okay? If the patient's on potassium-sparing diuretics, that helps us keep our potassium. On an ARB or an ACE inhibitor, again, affects our ROS. Okay? Crush injuries, we just talked about, or massive cell destruction, so burns, which you guys are going to learn about soon. Tumor lysis, so breaking down of tumors quickly. Infection, septic patients are at high risk for developing hyperkalemia. Acidosis. Why acidosis? Right, good. You're exchanging hydrogen and potassium. So my body's like, let's get back to alkalosis. I need to put this, it's like hiding all the, dirty clothes in your room. I need to put this somewhere. And so they're starting to put the hydrogen back in the cells. And when they do that, your cells are like, well, I need to release the potassium back to you. So the potassium comes out. Okay. Uncontrolled diabetes. Obviously, that leads to poor kidney function because they're destroying our kidneys. And also diabetics are at higher risk for hypertension, which means that they're probably on some kind of ACE inhibitor, which is like a double whammy. So they're also at higher risk for developing hyperkalemia. With their ACE inhibitor, they could also be on a potassium-sparing diuretic to help control their hypertension. Salt substitutes. So a lot of times we tell our heart failure patients, you can't have salt, so use a salt substitute. Well, salt substitutes use a lot of potassium. So if they're using that a lot, it could cause hyperkalemia. And it's dangerous for our heart failure patients on digoxin because now we're giving ourselves lots of potassium and we're taking up too much seats, and then the dig isn't working like it should. Okay? And then penicillin contains potassium. It can cause hyperkalemia. So, clinical manifestations, assessment, age. Okay, so our kidney function decreases with age. So that will automatically put our patient at higher risk for developing hyperkalemia. Chronic illness like diabetes or a kidney disease, a kidney issue, medical or surgical treatments. Okay, we're going to monitor our urine output. Obviously, if we're not making any, we're going to be holding our potassium. Nutritional assessment, what are they eating, and home medication assessment. All right, so they're at high risk for developing cardiac arrest. Is the most common cause of death for our patients with hyperkalemia. Okay, they have those tall peak T waves. There's my witch's hats right there. You'll see a lot of ectopic beats. What's an ectopic beat? PVCs. A beat other than your SA node, but PVCs. Could be complete heart block, could go into asystole. Well, that will obviously circle back to cardiac arrest. VFib, and then hypotension can develop because of poor muscle tone. Those are the most severe ones. So these are the not so severe ones, the ones that might be subtly sneaking up on you. Tingling and burning, numbness in your hands and feet, leg cramping, fatigue, weakness, increased respiratory distress. As things get worse, a worsening sign is increased muscle twitching and flaccid paralysis. Okay, you'll also see increased GI motility because now we're less stimulus, so I can go, which gives me hyperactive bowel sounds, and those patients will often have a lot of diarrhea. So what are we going to do? Our goal is to reduce potassium levels, prevent this from reoccurring, and ensure our patient is safe during this electrolyte imbalance. So we want to ensure that there's an IV in place to administer drugs, but also to manage cardiac arrest if that happens. Okay, especially if your patient's having a lot of PVCs and arrhythmias, because that means that your heart doesn't like the potassium being so high, it's irritated. Okay, drug therapy is our main intervention. Okay, so the first one, if your patient's not in kidney failure or having some other kidney issues, you can try to give a fluid challenge followed by some furosemide, so that helps get rid of that fluid but also take that potassium with it. Okay, so they might try that. That's only if your kidneys are functioning well. If they're not functioning well, this might not happen. Okay.
Could you explain that, the fluid challenge? Why do you do that?
So fluid challenge, like I might give you 500 mils of normal saline over the next hour, then I'm going to give you 20 milligrams of Lasix to help pull the extra fluid off and the potassium. Because Lasix is a loop diuretic. It gets rid of our potassium. Good question. Okay, next drug is sodium polystyrene sulfonate. That has lots of words to it. It's Kayexalate. You'll never hear it called sodium polystyrene sulfonate in the hospital. Okay, but you may see it on a test or on the NCLEX that way. But that's really Kayexalate. Okay, we give it PO. You can give it, it's liquid. You can drink it, which is gross. You can put it down in D2, which they may prefer after the taste, or you can give it as a rectal enema. And it helps us get rid of potassium via stool. Okay, so it takes a couple hours to work. It's not a quick fix. Okay, it causes large bowel movements, get rid of lots of potassium. Okay, Patramir also is an oral medication. It's good treatment for chronic hyperkalemia, but it also binds with other medications. So you cannot give it within 6 hours of giving another oral medication because it will bind with that medication. It won't allow that medication to work. But it helps you excrete potassium in your stool. Okay? So those two drugs take a little bit longer to work. If I have a patient that's in hyperkalemia and I need to treat it now, then I'm going to give them regular insulin IV, dextrose 50%. So that's D50W. Have you guys seen that at clinicals? Comes in a huge syringe. It's thick. It's like for pushing maple syrup through your patient's IV. And I'm going to give calcium gluconate or calcium chloride. And that is going to help bring that potassium temporarily into my cells while we figure out how we're going to treat your hyperkalemia. Okay? So our regular insulin brings that potassium into the intracellular space using the sodium potassium pump. Our dextrose 50% keeps our blood sugar stabilized. Okay, but you still need to be checking blood sugars. Our calcium gluconate, sometimes they'll give calcium chloride. It protects our heart muscle from ventricular fibrillation. It kind of stabilizes that membrane potential and restores electrical gradient so the heart's not so flippity-gibbet. Okay, that was a made-up word, not excoriation. Flippity-gibbet. Spell that. All right, so those are the 3 drugs that you'll give if you're treating it IV. The other thing they might start if they're very acidotic, metabolically acidotic, is a sodium bicarb. Okay, because that will help our body fix the acidosis going on, and so our body's not trying to push the hydrogen in and get the potassium out. Okay, albuterol can help shift potassium from extracellular space into intracellular space. Okay, and then hemodialysis, especially if you're in renal failure and you have hyperkalemia, is about the only way we're going to do a long-term treatment for you. Okay, and getting your potassium low, because that shift it using the IV medications will only correct your hyperkalemia temporarily. So if I'm a renal patient and I have high potassium, well, that'll treat it for a little bit to protect your heart so you don't go to those ventricular arrhythmias, but we're going to have to do dialysis to stabilize your potassium level. All right, so interventions. We're going to remove all potassium from our IV solutions. Okay, that should be from, not for, sorry. Stop any oral potassium that they may be getting or receiving. Okay, potassium reduced diet. No Mrs. Dash. Sorry. No salt either because you're probably a heart failure patient and you can't have salt. Okay. Continuous EKG monitor. Okay. And then the digoxin effect, so our digoxin may not be working quite as well as we want. That doesn't mean that we go and start giving them more digoxin. Okay, that just makes our serum dig level higher, so when we treat our hyperkalemia, then our patients will have a higher digoxin level. Does that make sense? Yeah. So treat the hyperkalemia, your digoxin level should become therapeutic again once you get your hyperkalemia under control. Okay? And then teach patients who are at high risk for developing hyperkalemia which foods are high in potassium, signs and symptoms of increased potassium, when they should come in and get their labs checked. Okay. We're going to touch on fluid volume excess, and then I'll let you guys go. Ooh. Oh, we also have diuretics in here too. Wow. Maybe I should stop here.
Yeah, let's.
I think we should. All right, so I